Okay. So thank you very much, Jens. I'm very, very sorry that I'm not there, and I I tried to be there, but yesterday the first leg of my flight to Copenhagen was severely delayed, so I was told that I would have missed the connection, and there was no other way to get there. So I had to change my plans, and I'm so sorry to impose you another remote um, um, uh, presentation. Um, um, so I will be um, I will be covering very briefly a very complex uh, topic, and that is prediction of function in children with cerebral palsy. And the uh, it's a very of course complex task, and to some extent it's a frustrating one because we know how hard it is to predict function in our babies, but on the other hand we should be very comforted by the fact that we cannot predict the outcome precisely, because this is exactly due to the fact that brain damage is not the only factor that it's actually um, determining our outcome, the outcomes of our babies. And what we actually do as rehabilitators, as families and empowered families and social environment and um, enrichment in general, will change the course of things. And that's exactly why we can't predict everything from the start. One thing we can certainly consistently predict in a very powerful way is the fact that we will develop cerebral palsy, yes or no. We know that in the international recommendations that were published some years ago, we showed that it was shown that if we have an early red flag that could consider that a newborn detectable risk, then we can actually be fairly good in assessing whether that particular baby is going to develop cerebral palsy or not. And we know that in this kind of flow of things we should do in those babies, MRI plays a pivotal role, because it really gives us a very strong input on whether our baby will be at high risk of developing CP or not. What emerges from literature, though, is that imaging is not the only tool we should use, is not a tool that can be used on its own. It really needs to, the information from MRI really needs to be triangulated with clinical information coming from more clinical tools that are more focusing on function actually, and on the clinical impairment. And that's why the guidelines so far tell us that of course you need MRI, but you also need other tools such as general movements or the Hammersmith, which are clinical tools. And a few years ago, 4 years ago, we tested the hypothesis that triangulating these tools would make it much better in terms of diagnosis and prediction. And we actually found in a cohort of more than 400 children that using high GMs and neuroimaging, is actually a very, very powerful means to achieve an early diagnosis. And as you can see here in this slide, GMs and neuroimaging are particularly strong in showing a high specificity and sensitivity. The hind at a very early stage, 3 to 6 months, is still some false positives and negatives. So we're very lucky to have in sort of our team that part of the guidelines, but also part of our project that is called Born Together, that involves Denmark heavily as one of the main partners of the project, as you probably all know. We're very lucky to have on board Linda de Vries, who is one of the major experts in neonatal neuroimaging. And so this is the first slide of a presentation that will be launched as part of the e-platform of the Born Together project next month, within the next month. We recently had her in our summer school at the Born Together summer school we are running every year in July. So a month ago, she was with us and presented a very beautiful piece of work on the role of MRI in predicting cerebral palsy. And of course, there are a lot of aspects that are very important to look at. I'm not going to go through that because probably most of you are familiar with those, but certainly we can, by doing a good neonatal MRI, have a strong prediction on whether the baby is at very high risk or not of developing cerebral palsy. One classic example, and Linda has produced a lot of evidence about that, is of course, the posterior limb of the internal capsule. We know that if we scan babies at preterm babies in an early stages, and we see this kind of lesions that are actually still progressing, and so it's still difficult to predict the outcome. These are unilateral lesions, but if we wait for term age, Linda has shown very nicely that the posterior limb of internal capsule is actually a very strong biomarker of abnormal outcome, because if you have a clear asymmetry or an absence of one, or asymmetry of the signal at the plic, you are very likely to develop CP with the precision almost close to 100%. And of course, the plic, this is not surprising, as the posterior limb of the internal capsule is such an important pathway for such an important area where the corticospinal pathway is kind of concentrated, and so this is not surprising at all. And if you look at studies in babies that are born at term, for example, this is a very beautiful recent review paper this year in pediatric research in babies with perinatal arterioscemic stroke. Of course, the plic again comes out as a biomarker, something to look at carefully in terms of sensitivity and specificity. Of course, this is just one of the key elements. Another important area to look at, of course, we all know it's basal ganglia. We know how basal ganglia are relevant and important to, especially in term babies, to focus on. And looking at the severity of involvement of basal ganglia can also give some insights on the severity of cerebral palsy. So there are certainly key areas that already at birth or in the very early phases of development, when the brain still has to cope with the damage, and so plasticity still has to unveil. There are areas that are very strategic, and if they are affected, the chances of developing cerebral palsy, of course, is extremely high. But as far as function is concerned in a more global way and in terms of severity, the task is much harder. It's much harder to predict the severity of the different impairments and the different functions. A very interesting paper that comes from the experience of the surveillance of cerebral palsy in Europe collaboration, which is something that as Europeans we always consider very important in the last 20 years, 15, 20 years for CP. There is a suggestion of using a classification that basically divides and groups the children with CP in 5 groups: maldevelopment, white matter injury, gray matter injury, miscellaneous, and normal. And in this paper, the authors try to understand from the register what is the outcome and in terms of function in these different groups. And so, for example, maldevelopments, that's disorders of cortical malformation or other maldevelopments like holoprosencephaly, Dandy Walker, and so on. This is a very heterogeneous group. And so we know that when we have that, the prediction is kind of complex because we can have, in half of these children, we can have severe intellectual impairment, we can have epilepsy, and we know how important is epilepsy in these children in terms of changing the prognosis in terms of cognition, for example, but in terms of development in general. And we can have severe visual impairment in 15% of those. And so in this group, there is a very potentially a great span of severity in all these different aspects. But if we look at predominant white matter injury, for example, and this includes all PVLs, IVH with hemorrhagic infarction, a combination of those. Again, of course, we'll have a lot of bilateral spastic cerebral palsy, very little dyskinetic or ataxic. Generally, the gross motor function will be less severe than what we saw for maldevelopment. So more than 60% of children would develop a GMFCS1 or 2. But still, we have 1/3 with intellectual impairment. We have 20% that have active epilepsy. And we know how, again, these are factors that really can change the outcome. And the way we treat those, the way we manage those is so relevant for the natural history and therefore for the prediction of long-term outcome. And then, of course, the big group of predominant gray matter injuries, in which we have basal ganglia lesions, but we also have arterial infarctions. So that's probably why in this subgroup we have a lot of unilateral spastic CPs. And again, the severity is similar to what we saw. Epilepsy, since these lesions involve the cortical gray matter, is more frequent than in the previous subgroup, and also, again, a lot of variability, and CVI is also present. So, if we look at if we use MRI to kind of group our babies with risk of CP or children with CP, and depending on the type of lesion, we of course have some insights on the future, but there's still a lot of variability. More than 10 years ago, we did this first systematic review of papers, putting together, focusing on motor outcomes in children with CP, with Ross Boyd and group from Australia. And again, the picture is very similar: malformations, white matter damage, gray matter damage, and let's not forget that we have also infants that have or children that have a negative MRI. So we know that this can inspire us and can direct us towards the overall severity of the outcomes, but the actual fine prediction it's much harder in terms of unless we were talking about the extreme cases, the severe cases, where of course we know that it's going to be severe in all different domains. The fine tuning of our prediction is very complicated. More recently, the group of Velsortibus basically replicated the first systematic review, focusing on the papers that were published after the first systematic review, and it's basically it's a confirmation that of the findings that were observed in the first review paper. So I think this again stresses this idea that it's very hard to predict, and that is because we are just looking at one aspect of the story, and therefore we cannot be fully precise, because there are a lot of other components that are not accounted for when we just look at the brain damage. And again, to me, this is very reassuring, because it means that our role as rehabilitators is important as promoters of good development, as promoters of parental empowerment. I wanted to, so basically what we know about our ability to predict is affected by the fact that basically there's a lot of plasticity going on after the damage has occurred, and therefore we have to kind of cope with that reality. And these includes, for example, the fact that as far as motor function is concerned, there's not one single structure. Of course, the corticospinal tract is very important, and we sort of that makes a lot of sense. But then there are a lot of other structures that are involved in motor function. Let's think at the basal ganglia. Let's think of the cerebellum. Let's think of the sensory areas, and therefore the picture is much more complex. We kind of had a grasp of that some years ago when we did a study on the connectivity of the corticospinal sensory and motor systems in babies with unilateral brain damage, in children with unilateral brain damage. And we were looking at the asymmetries of the posterior limb of internal capsule. So we were very interested in seeing these asymmetries and how they could predict the outcome. But we also looked at the thalamocortical fibers at the same time, and the asymmetry of thalamocortical fibers. And we were kind of surprised at that time that this was actually the most predictive index in our cohort, even more than the asymmetry of the corticospinal tract, posterior limb of internal capsule. So this is really, I think, a good example of how the complexity of the system is actually affecting the outcome. And so we can imagine that is in this maturation and development of functions, the fact that thalamocortical fibers are also affected is kind of playing a key role in long-term outcomes in terms of sensory motor function. And so the correlation with AHA, with Melbourne, with Jepson, were all stronger if we looked at the asymmetry of thalamocortical fibers than if we looked at the asymmetry of the posterior limb of internal capsule tracts. And so this is of course fascinating, and makes our task of predicting the outcome harder. We can look at other structures, for example, the cerebellum, and see that in children with brain damage, if we look at the asymmetry of the cross-cerebellar connectivity, again, we will find a good correlation with function, in this case with the AHA, which makes a lot of sense, because then you need a good connectivity with the cerebellum for coordination and bimanual activities and so on. So really, the involvement of these different structures is very complicated in terms of prediction, because we can have a different involvement of different structures. And if we look at them one by one, we see an overall correlation, but on a single subject level, it would be necessary to put together and to include in our equation all the different possible factors. And we're only talking so far about motor function. So this gives certainly an idea of the complexity of the system, but we can use other tools. We can use, for example, tractography, which is also a very useful way to capture neuroplasticity. But if we think about it, when we move on from babies to older children, it's not really about prediction anymore, but it's about actually finding structure-function correlation. So the picture that we have in our MRIs in older children are not only the result of the damage, but already the result of what happened in terms of plasticity and reorganization. So we are we are a little bit a step farther, since we're not really predicting, but we are observing and taking pictures of a brain that is already undergone a lot of plastic changes. And this uncertainty in terms of prediction is not only does not only apply to the sensory motor system, but, for example, also to the visual system. The visual system is also similarly affected. And if we have, we study the relationship between brain structure and function and CVI, as we did with Sweta Phillips a couple of years ago, we really fail to find very strong predictors. Of course, if you have big lesions, if you have extreme pictures, that involve visual structure, you can be fairly sure that there will be some elements of CVI and sometimes severe CVI in the child. But in all the intermediate situations, it's very hard to make a correlation between the different sides of the damage and CVI. And again, I think this is telling us how important it is what happens after the damage has occurred in our lives, and what happens in terms of intervention, what happens in terms of environmental enrichment in the interaction between all this and our individual profiles. If we focus on the single person that we have in front of us with the brain damage that we observe, the avenues from the damage to the outcome are so complex, as Alan Curtin has highlighted very nicely in focusing on unilateral brain damage and perinatal stroke, that really we have to accept that in moderate damage, we are unable to fully predict the outcome because, again, we lack some of the elements. So I'm not sure. Sorry, I'm not sure if how